Remind me again.
I went home on a Monday night, and that will be a week ago this Monday night.
Okay, so you were home
Going
10
into
days
the
now.
2 weeks.
10 days now. All right. How are you feeling now?
You know what? From the recovery from the,
Surgery? Mm-hmm.
Lord, wonderful.
Good.
Amazing.
Okay, are you eating well?
I'm eating, but and I'm pooping.
Okay, good. You're
That's
eating well though,
normal.
right? Are you eating good amount? Meals?
As
Appetite
much
is good?
as frequently as yes.
Mm-hmm.
I
Okay.
am trying to put the weight back on.
Okay, good.
I eat early in the morning with
Mm-hmm.
oatmeal,
Okay.
and like I diced up little fresh pears today.
Right.
Then I had a scrambled
Just
egg.
some scrambled egg
Mm-hmm.
and some chili relleno left over.
As much as I could eat, I eat, and then I get hungry and I'll eat
Okay.
again.
Okay, so here's what we're gonna do. Okay, it's your case is not something very straightforward. Okay.
Uh-huh.
Primarily, well, I mean different layers of complexity here.
Yeah.
I guess the main issue really is what's in the pancreas. Okay,
Right.
that's really the main issue, and we may or may not be able to give you an absolute 100% definitive answer. Okay, you realize that, and because the camera couldn't go farther down low enough.
Right, right.
So we might be able to get some additional information will give us a better idea whether that's cancer or not, or more likely one way or the other. Okay.
Yeah, yeah.
So one is let's get a PET CT scan. Okay.
I will do that.
Yeah, a PET CT scan basically will give you injection of a radioisotope labeled glucose. The sugar will go to anywhere with increased metabolism.
Okay.
So if that little half inch, 6/10 of inch of something in your pancreas takes up a lot of sugar, then it tells us it's more likely to be cancer. Okay? It does not tell you it is cancer. Okay, it tells you more likely it's cancer. And then also there's another piece of maybe indirect evidence we may try to get is some blood tests. Okay, so some cancer will make proteins that's in your bloodstream. Okay, and we did check some of the markers in your body, and they can be made by colon cancer. Okay, but since your colon cancer is removed, we can look at this marker again. If these markers all go down, then
That's good.
kind of it doesn't tell you that's not cancer in the pancreas. Certainly, it's consistent with it's not cancer. Okay, it's a little convoluted because if those marker on the other hand is going up, then that means what's in your pancreas is more likely to be cancer. Okay, right. So really, these two pieces of information will give us a little better idea what's in the pancreas. Okay, and then we can sit down and talk about what to do with the colon cancer. I kind of give you a very general idea about that colon cancer, but again, the reason we talk about the colon cancer is the cancer may come back. Okay. Yeah, because your cancer had 10 positive lymph nodes at the time of surgery.
Yeah,
Those are the folks with positive lymph nodes. Actually, they have a quite high risk of colon cancer recurrence. However, we still have to look at it in the greater context of what's in the pancreas, because if the pancreas is cancer, then if we don't deal with that, it's kind of moot point. Try to deal with a possible colon cancer recurrence wouldn't make too much sense, right? So that's why the most important thing is to try to figure out what's in the pancreas. Okay, so that's pretty much what I have to tell you.
Well, I talked to my sister today,
Yeah.
and they're dealing with something pancreatitis.
Well, the pancreatitis people can have it. Basically,
She's dealing with
any part of the body can have itis. Basically,
Yeah.
is inflammation. Okay, and the pancreatitis and a lot of things. Can give you kind of similar findings on a CT scan. So just based on CT scan, just based on scan, we cannot really be definitive say you have cancer or not. Yeah.
You were saying that her colon cancer could come back.
It could, yes.
But it may not.
Because?
It could.
Because, okay, so let me try to okay, all
Go
right.
back.
So let's just say this is your colon, okay? It's a tube, right? The cancer usually starts inside, okay? Inside the lumen of the tube, okay? So as it gets bigger, usually also grows deeper into the intestinal wall, okay? And then it can go to the lymph nodes in this area,
Yeah,
okay?
pictures of it.
So what happens, what we have observed is, when you look at all the patients like Regina and you take out the colon, right?
Yeah.
And some of them, the cancer can come back.
Oh.
And so, not everybody, okay? Some people are cured by the surgery. So then the next, intuitive question is, why it comes back? Because all the surgeons say, well, I removed all of it, which is true. So because it can come back, then the only logical explanation is there's some cancer you couldn't see that's left behind. So then the question becomes, who has the cancer that's left behind? Okay, how do we know? Okay, the short answer is we don't know, because if I knew, I would have told you, right? And so, and also because it's something we cannot see, so by definition, I don't know. So then really it becomes another,
Guessing.
well, it's an educated guess, okay? It's kind of like the way I explain to everybody, it's kind of like how your insurance company decides how much you will charge your car insurance and how much they decide to charge you. So you use the existing knowledge, try to predict the future, okay? So then, for example, if you had a drunken driving history and DUI, then your rate is going to go high, right? So what we learned for colon cancer is, if you have lymph nodes has cancer, which kind of makes sense, right? Because if it spreads to the lymph nodes, then more likely you have cancer we cannot see. But still today, the best we can do is still, all we can say is more likely. We still don't know for sure. For example, you had a stage 3 colon cancer, which means goes to the lymph nodes. And the stage 3 colon cancer really we look at all, if we had 100 of stage 3 colon cancer patients like you, all had a surgery, probably 3-4 years later, about half of the patients, you will see some cancer recurrence, okay? So it can happen. So that's why sometimes we actually offer patients chemotherapy. Again,
Well, that's what I was thinking.
Right. That's really the reason why we recommend patients have chemotherapy, because all we know is you have increased risk. So chemotherapy is to reduce that risk. But still, this can, in your situation, we have to talk about this in the greater context of what's in the pancreas. Without knowing what's in the pancreas, it's somewhat difficult to make that decision, right? So that's why we're going to try to do the best we can to figure out what's in the pancreas. But again, I try to tell patients that we function a little better in almost all circumstances if the answer is binary. In other words, if the answer is yes or no, black or white, but sometimes it's a maybe and it's a gray, So this is one of you, unfortunately, kind of fall into that category. So we're going to try to move the needle to one direction or the other, try to figure out what this is. Okay, that's really.
But you did say that the cancer that you removed was stage 3.
That's correct.
That's the
correct.
first time we've heard this. We haven't heard any pathology results.
Right. It is a
so-
stage 3 cancer.
Okay.
Yes.
Okay. And then I think that we met Dr. Lavochkin yesterday, and he explained to us similarly, pancreas is our big issue.
Right,
We need to
exactly.
fix this, figure this out.
Because if we don't know what's in pancreas,
Yeah.
we're kind of handicapped to try to guess what to do for colon.
Yeah. So, is it fair or reasonable to ask if there was no pancreas issue and we were dealing with the stage
Colon.
3 colon and understanding that I think he said he took out like 24 lymph nodes or something,
Right,
and like
uh-huh.
of those
10 of them.
10. Okay.
Right, yeah.
He said 7. I like his answer better. He was talking off the top of his head. He said, I don't know for sure. 10. Okay. So with that information, is it fair to say that you would recommend chemotherapy for her?
Okay,
with the
let me. Okay, so let's.
Yeah, I wanted to
again.
ask
Okay,
about that.
let's walk one step back first. Okay, so. As I said, in general, we do offer patients who are in good physical shape and chemotherapy to reduce their risk. Okay, so I'll give you some general ballpark numbers so you understand the context a little bit. So when you look at, again, just like 100 patients with stage 3 colon cancer, okay, if you do nothing, about 3-4 years later, 50 of them you'll see cancer recurrence. Okay, cancer recurrence can be in the liver or other parts of the body.
I see, yeah, 'cause it's a
So then what can we do to reduce that 50? Okay, so it is chemotherapy. Okay, if you receive chemotherapy for roughly about 6 months, I'm going to explain chemotherapy in a minute, then what you're going to see 3-4 years later is you're going to see 25 patients will recur. Okay,
I
so
see.
so wouldn't make it go down to zero. Okay, it depends on your half glass full, half glass empty. We think that actually it's decent, but some people say, well, it depends on how you look at it. Regardless, it really just reduce the risk of recurrence by half, basically, right, from 50 to 25. So then what is chemotherapy, right? So if I told you it's a cup of coffee a day, then we wouldn't even have this conversation, right? If I told you I'm gonna make you sick every day, then we wouldn't have this conversation either, right? So usually, again, somewhat in the middle, right? We like it black and white, but it's not, it's gray. So the chemotherapy overall, I would say actually, when we think about the 10 being the most difficult chemo, 1 being the easiest, it's probably 4 or 5, somewhat in the middle,
I was
okay?
wondering, yeah.
For example, it does not typically even cause you to lose your hair.
I was just wondering.
And nausea, vomiting for most patients, it's actually pretty manageable.
Oh,
And there are different ways of giving that to you. For example, one of the common regimen actually is you just take a pill for 2 weeks, and then you have a week off,
yeah.
and you repeat this 8 times. Okay, so that's about 24 weeks. That's 6 months, right? That by just doing the pill, okay, you more or less get it down to 30 patients will recur. Okay, so where's that extra 5? So right,
Yeah, yeah.
you reduce at 50, exactly 50 to 30. Okay, so where does the extra 5? The extra 5 actually comes from another IV drug will be given to you once every 3 weeks. Okay, so basically 2 chemo drugs. Okay.
Oh,
So the pill itself actually works quite well already, okay? But we learn adding the IV works a little better. However, the IV actually is the one can give you a little more side effects, okay?
oh, is that right?
Yeah. So the IV, the main problem with the IV drug is it can cause something called a neuropathy. Okay, you guys, if you know people with diabetes, many diabetics have a diabetic neuropathy. So
If they have no feeling in their feet or numbness and everything.
exactly. So mostly
That's what
numbness and
those
tingling, pins and needles, and
Yeah,
right. Well, many people have some degree of neuropathy, and if we be careful, we certainly can avoid for the neuropathy to get too severe. But the main problem is neuropathy for that drug. Okay.
Yeah.
So that's really in the essence what that chemo is. Okay. The pill is mostly pretty easy. The pill can give you a skin reaction. Some
Yeah.
people may have diarrhea, but overall the pill is pretty mild.
That's what my brother's taking for his bone cancer right now.
Yeah. So well, the different chemo
I
pills.
understand,
Yeah,
but
right.
I relate to my family because
Yeah,
we're
sure.
so canceled.
Right.
So we have
So,
to run to our
right.
family.
The pill itself actually carries most of the heavy workload, but adding the IV helps. So
Oh.
sometimes folks, I think they're kind of borderline candidate, and sometimes I just recommend take the pill only.
And how do you,
Okay.
what kind of pill is it?
It's just it is a chemo pill actually.
And is
Liquid
it,
or
do you
solid?
swallow it or
It's-
crush it or
It's
what?
one of the bigger pills.
I can't swallow.
Oh yeah, I remember that. So
I'm
okay.
Crush
just
it up?
non-swallowing lady.
I think he can. I think he
Oh
can
my
crush it.
God.
Well, okay. Let's hold on. There is an alternative. Okay, for the
I have to
pill.
have it in liquid or something.
Okay.
I'm just
I
not-
don't know actually. So let me see if can we crush the Zaloda.
Can we crush them? That would
I
be
don't
fine.
know. Yeah. Let me see.
I think, and I know we don't know